Good morning and afternoon. My name is Tracy Cook, and I'm with Sachs Healthcare Communications. Before I introduce our moderator, James Simmons, and our speaker, Nicole Kupchak and Mike Helbeck, I'd like to show our audience how to send questions and comments. You can type them directly into the questions box on the GoToWebinar control panel. Our moderator for today is James Simmons. Dr. Simmons is currently a hospitalist nurse practitioner at St. Francis Medical Center in Los Angeles, California. He is a guest lecturer at both the UCLA School of Nursing and the University of Illinois Chicago College of Nursing. He is a clinical ambassador for the CDC's Let's Stop HIV Together campaign and continues to emerge as a leading nationally recognized voice advocating for marginalized communities in healthcare. Dr. Simmons is also frequently featured as a health expert on national television, radio, podcast, and social media programming. Dr. Simmons, welcome.
Thank you very much, Tracy. What a lovely introduction. I appreciate it. And okay, we have so much to get to. This is, I'm going to use someone else's words because I like it, chock-a-block full of information. So I want to jump right in. The title of today's webinar is Improving Survival from Cardiac Arrest. What does it take? And speaking today on this super awesome topic is Nicole Kupchak and Mike Helbeck, who you see in front of you here. So our speakers, Nicole has practiced as a critical care nurse for more than 20 years. About 15 years ago, she began working at Harborview Medical Center, a change that spurred an interest in resuscitation, thank God. Shortly thereafter, Nicole was part of a multidisciplinary team that was one of the first in the US to implement therapeutic hypothermia after cardiac arrest, something really common now. As a part of this effort, Nicole was responsible for protocol development and has published numerous papers on this topic. In 2013, Nicole Kupchak Consulting and Education was founded. Nicole, welcome. And our second speaker is Mike Helbeck. Mike is currently a Washington State certified nationally registered senior paramedic and Director of EMS Training and Education for EMS Associates. Mike worked for 25 years as a firefighter paramedic for the city of Bellevue's Fire Department, Bellevue, Washington, that is, until his promotion to Director of EMS Training and Education in Western Washington. He has received speaking invitations from many of the nation's largest EMS conferences and EMS agencies nationally and internationally. Mike, thank you for all of your work and welcome. All right, so a couple of particulars I got to get out of the way before we get to the good, juicy stuff. Our speakers do have disclosures. Nicole is part of the Speakers Bureau for Stryker Medical and Baxter Healthcare and a consultant with Baxter Healthcare. Mike is a part of the Speakers Bureau for Stryker Medical as well and faculty at Seattle King County Resuscitation Academy. Also, of course, you want to know this part, right? This is good for continuing education for nurses, EMS professionals, and respiratory therapists. 1 contact hour for each of y'all. And a link to obtain CE credits will be available at the conclusion of the webinar. And I want to prepare you for this now. There will be a link for RTs and nurses, and there will be a separate link for EMS. We'll talk about that at the end, okay? A big thank you, of course, to Stryker for Stryker's support of this educational activity. All right, all of that is out of the way. I am done rambling. You'll hear from me again at the end. I now want to turn it over to Nicole.
All right, well, welcome everybody. We're so excited. There are a lot of people joining us today. So we're gonna shut off our cameras and officially get started. All right, so again, the title of today's webinar is called Improving Survival from Cardiac Arrest. What does it take? So what Mike and I are gonna do is from a 30,000 foot view, just talk about what it takes for a system to really make improvements to maximize our outcomes from cardiac arrest. And we're going to talk about differences between the hospital approach versus an EMS approach, but realizing we all really do need to work together. So learning objectives, we're going to talk about the importance of early recognition of arrest or deterioration, more importantly, especially in hospitals. Talk about early, high performance, high quality CPR and effective early defibrillation for shockable rhythms. And we're going to weave in the 2020 guidelines that were published last November. We're going to talk about just high performance CPR metrics and how you integrate training and feedback into your resuscitation programs. And then finally, we're going to talk about possible future practices and different directions resuscitation might take. So this will be kind of exciting, a fun way to cap off the webinar. So our plan for today is we're going to talk about what we know for sure. High performance CPR is going to be defined. We're going to talk about different practices that are showing some promise in the literature. And then we're going to talk about different things that the future might hold. And Mike is going to just wrap it all up at the end, discussing our top 5 places to start for your hospital or EMS system to improve resuscitation practices. Now, Mike's going to pipe in and chat just briefly about the Resuscitation Academy.
Wonderful. Thank you, Nicole. Yes, this is a website that everybody can see called resuscitationacademyorg. We've actually built a QR code for you as well. So if you've got it in front of a screen with a smartphone or an iPad or some type of tablet, just hold it up to that and that QR code will take you directly to the website. Everything behind there is free. We only ask that you sign in so we know who you are, where you're from. And then once you open that door, Nicole, everything behind there is free for you. And I wanted to just make interest of this ebook called The Art and Science of Resuscitation. And I believe that you'll really enjoy that book. Thanks for that.
Yeah, no, and as a hospital provider, I actually went through the Resuscitation Academy a number of years ago, and I did a ride along with King County Medic One. And I have to say, like, I learned a lot that I was able to bring into the hospital. So I can't say enough good things about this program. But in general, when you look at cardiac arrest and resuscitation, it takes an entire system. So it's imperative that lay people are providing bystander CPR, that we know where our AEDs are. And if any of you have followed me for any amount of time, I was involved personally in a cardiac arrest. There was a woman that had an arrest at the airport while I was waiting for my Uber. And, it was interesting. Me and 2 other women, we provided high performance CPR. I actually even had my metronome turned on my phone. But we didn't know where an AED was, and no one could find one. And then come to find out later, there was an AED only 40 feet away from us, which is, and no one knew. But, so some things that need to happen is, like I said, early bystander CPR, early and effective defibrillation for shockable rhythms, if this is an out-of-hospital cardiac arrest. You've got to have an EMS system who has just embraced high-performance CPR, minimizing pauses, and we're going to talk about some of those other components. But, just as important is the care that's provided at the hospitals. So if you've got a patient who maybe was having a STEMI, do you have a cath lab that's available? What do your critical care services look like? Are these patients getting optimal post-arrest care? Is their temperature being managed? And all of that together as a system leads to better outcomes. So for example, if the pre-hospital setting is not providing high-performance CPR, honestly, probably it's not going to make a huge difference what you do in the post-arrest phase. And I will say, conversely, if you've got an EMS system that's providing amazing care, but a hospital that drops the ball, we're not going to have great outcomes. And so I just truly believe that hospitals and EMS systems need to work together to optimize outcomes. All right, Tracy, we're going to launch our first poll of the day. Oops, and the answer just came up, but I'm not really sure how that happened. Well, I guess it doesn't really help. Oh, there we go. Okay. All right. So according to AHA's 2020 statistical update, what's the bystander CPR rate and out-of-hospital cardiac arrest survival rate? So a lot of you just saw the answer. So if you get this one wrong, I'm not sure what to say. Go ahead and get your votes in. All right, Tracy, are you starting to see votes rolling in?
I am, thanks.
Okay, cool. We'll give you all a few seconds there to get your votes in. All right, so what are the bystander CPR rates and out-of-hospital cardiac arrest survival rates? And this is the average for the entire country. So obviously some cities are going to have better or maybe even worse outcomes than what the average is. So, okay, let's go ahead and wrap up the poll, Tracy. And what were the results? Okay, yeah, so most of you got that right because I showed you the answer. But yeah, the average bystander CPR rate is 39.2% with an out-of-hospital cardiac arrest survival rate of 10.4%. So can we make improvements? And the answer is absolutely. There are some cities, like for example, the city I live in, that have bystander CPR rates upwards of 60 to 70%, with a much higher survival rate. So, but it's not just surviving. Just as important, I would say, if not even more important, is like, what are the neurologic outcomes? And you can see here that we have about 250,000 cardiac, 350,000 out of hospital cardiac arrests per year, and survival to discharge with good neurologic outcome is about 8.2%. Now, I will say, you can see if you look at the survival rates with bystander CPR versus without bystander CPR, there is a big difference. So one of the things we really need to make sure is happening is just training of citizens in CPR. A lot of cities and a lot of different school districts require that people learn CPR, that students learn CPR before they graduate. So, you know, I do think we still have a lot of room to improve, and it's going to be focusing on basics of bystander CPR. Now, if we look at the hospital side, so this is an informal poll, but if we look at the hospital side, according to the Get With The Guidelines registry, what is the survival for adults who have an in-hospital cardiac arrest? And if so, you can kind of take a look at the percentages there, but the answer is C, it's 25.8%. We have about 250,000 cardiac arrests on the in-hospital side per year, and survival with good neurologic outcomes is 21.2%. So can we make a difference there? And I will say absolutely. You know, I led our Code Blue committee for a number of years at a big hospital I worked here in Seattle, and we did mock codes. We focused on just that first responder, and we were able to get our in-hospital cardiac arrest survival up to 35 to 40%, you know, depending on the month. And it's interesting, you know, as with anything, when training happened, our numbers got better. When there was a lag in training, our outcomes dipped. So, you know, it really, I think ongoing training is essential to improving outcomes. So hospitals and EMS have a lot of similarities. High performance CPR is going to be the same regardless if you're in the pre-hospital setting or the hospital setting. But I will say there are definitely some differences. So Mike, when you have a patient who's having a cardiac arrest, how are you finding them? Where are you providing CPR? What is the situation?
Oh, that's a great question. First of all, most cardiac arrests happen in the home, Nicole. They happen in the home, but certainly we'll find them in cars and ditches and Walmarts and on the street, but most of these happen actually in the home.
Yeah, and in hospitals, we always say, one of the things we always say is the best arrest in a hospital is the one that never happens. Really, in hospitals, we should be focusing on antecedents to cardiac arrest, on deteriorating vital signs. You know, the best arrest is the one that never happens. You know, no arrest in a hospital should be a surprise. And that's one of the things I always would kind of joke about, is like when people would say, oh my gosh, I'm so shocked that patient coded. Like, really, should you be? Because, you know, there is evidence and data that patients tell us with vital sign changes 8 to 24 hours before they actually arrest. And those are things we need to pay attention to. But Mike, if you had to guess, like, do you think most resuscitation research is done in the pre-hospital setting or the hospital setting? Like, if you had to guess, what do you think?
Well, it's clear to me, Nicole, that most of the research that we're reading as practitioners out there are usually in the out-of-hospital cardiac arrest scenario. That's been my belief. Not only am I part of a lot of those, but I've read most of these, and they tend to be all out of hospital, Nicole.
Yeah, and you know, so you're absolutely right. And so there were 2 studies that were published in 2019 and 2020 that revealed that only 6% of all studies done in resuscitation are conducted in hospital. Everything is out of hospital. Everything else is out of hospital. So when you look at, and I think it's really important to understand that. So when, you know, as a hospital provider, when we look at the research, we need to be asking ourselves, where was this conducted and how will that translate to a hospital bedside practice? You know, and it's interesting. EMS really focuses a lot on their resuscitation outcomes. I will say for hospitals, we struggle, and I think one of the reasons we struggle is that when you look at, like, so for example, my hospital, we had with the ER and in-hospital all included about 300 cardiac arrests per year. And then when you look at the sepsis, incidents, we're talking like 10 times the amount of septic patients. So where do you put your focus? And I think that is something that every hospital is really struggling with. And but you have to have a champion, whether you're in the EMS sector or the hospital system. You've really got to have a champion, someone who can lead the way on this. All right, so I'm going to hand over to Mike, and he's going to chat about what we know for sure.
What we know for sure. Well, thank you for that, Nicole. Thanks for starting us off and getting us going on that. So what do we know for sure? Where has the science taken us? What have we validated? What have we learned over the years? So let's take a little journey and make that happen for us. I think that it's important that we understand where this is going to go. So we'll get some control back of the screen here, and away we go. Tracy, can we advance this? So we start with a poll, actually, and the first poll, this is for Tracy to run, but it's a question of, what do you think the influence of survival is in out-of-hospital cardiac arrest? What's the biggest influence on survival and out-of-hospital cardiac arrest? I'll let the audience take a peek at that. We'll give them about a minute, and then we'll see what they have to say. I'm looking at the same answers up there, and I'm going to be curious to see what our audience has to say about this. Out-of-hospital cardiac arrest.
And I kind of gave away that answer, Mike.
Well, we'll just see. Well, we'll see if they've been listening or if they have a different plan. Maybe they have a different idea. So we'll start to wrap this up. Give it a few more seconds. All right, let's take a peek at this and see what you think. Well, clearly the audience either knows the answer or they've been listening very well, but there's no doubt about it, everybody. Receiving early bystander CPR is one of the keys to increasing survival in out-of-hospital cardiac arrest. Let's go take it back to our screen, and then we'll kind of push forward from there. So one of the, even supported by the the 2020 guidelines from the Heart Association, that they make the same point, that we know that early survival from out-of-hospital cardiac arrest can be absolutely managed and started by bystander CPR. In fact, for every 1 minute that goes by without any care whatsoever, the chance for survival drops by 10%. So we actually, communities, out-of-hospital CPR is really one of the keys to early, but I've got some other things I want to share with you. I'm not sure how many people have seen both the out-of-hospital cardiac arrest chain of survival and the in-hospital. I'll talk briefly on the out-of-hospital if you'll take it home on the in-hospital, Nicole. But the 2020 guidelines made it very clear. Early recognition of cardiac arrest, and there's something that comes into play there regarding ventilations or the attempted respiration of a cardiac arrest patient. But to include bystander CPR, engagement with 911 dispatch with telecommunicator instructions to do CPR. I've got a very, very cool audio bite coming up next, and early defibrillation. Nicole, could you take us on in-hospital and the 2020 guidelines?
Yeah, absolutely. And a link in the chain of survival that was added with the last guideline update was early recognition and prevention. And like I mentioned before, the best arrest in a hospital is the one that never happens. But if you look at the chain of survival, it's very similar. We need to focus on high performance CPR, early and effective defibrillation for shockable rhythms, and then really a big focus is on post-cardiac arrest care. In November, I'm going to be doing a webinar with Dr. Benabella, specifically going over the new literature on targeted temperature management. But, astute post-cardiac arrest care is essential. But, over 80% of in-hospital cardiac arrests have abnormal vital signs, like I said, 8 to 24 hours before their arrest. And most cardiac arrests are due to respiratory failure and or hypovolemic shock for whatever reason. So really no arrest should be a surprise in a hospital unless it's a cardiac patient who's infarcting who goes into VFib.
Yeah, I love when you shared that with me, how that I remembered that very well. So I have a very interesting case. I want everyone to just take a second. If you're multitasking at home or wherever you're at, I want you to listen to this. This is an actual call brought in from a reporting party to a dispatch center that incorporates and employs something called TCPR, telecommunicator CPR, or dispatch assisted CPR for some that don't know. This idea of recognizing cardiac arrest early using a program called No-No-Go puts in play early recognition and early bystander CPR. Listen as we move through this to these 3 key points. The telecommunicator or call taker is going to ask, is the patient conscious or awake? It's binary, it's yes or no. The telecommunicator or call taker is going to say, are they breathing normally? Yes or no. If it's 2 no's, then we go. If it's no to this, no to that, then they're going to start CPR. So let's listen to this audio and see if you can pick up the key and appreciate the gravity of the call. Go ahead.
911 emergency.
Yes, medical. Ma'am, go with your address.
Ma'am, what is the address? Okay, is this for you or for someone else?
My husband, he started making funny noises and now
Okay,
I don't think he's breathing.
Is he
He's turning red and purple.
Is he conscious right now? Is he awake?
No,
Okay, and he's not breathing normally?
no.
Okay, then I need you to get him flat on his back on the floor. We're going to go ahead and start CPR.
Well, he's flat in bed, in our bed.
Okay, I need you to get him flat on his back on the floor so we can start CPR.
Okay, all right, hang on.
Okay, we're getting help.
Wow, 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 wow. I'm not sure if many of you have actually heard a conversation between a dispatcher or telecommunicator call taker and a reporting party, but that's a powerful message. No, no, go. Nicole, I'm going to push through this couple animations. Would you talk briefly about the 2020 guidelines for both shockable, non-shockable rhythms from the HA, please?
Yeah, one of the things that was maybe a tiny bit different in these 2020 guideline updates were that in non-shockable rhythms, there's some evidence of, obviously high performance CPR, but giving epinephrine a little earlier. Now, for shockable rhythms, I want to be really clear. For VFib, you defib. And you've really got to focus on early high performance CPR for shockable rhythms, but early and effective defibrillation. Epinephrine is not going to get somebody out of ventricular fibrillation.
Exactly.
And the evidence on amiodarone and lidocaine, really we give them, but our focus really should be on defibrillation versus a lot of our medications. We give the meds, but the focus should be on high performance CPR and early and effective defibrillation. So
Perfect.
that was just something we wanted to call out because I feel like there's some confusion around this. So just wanted to make sure that was really clear.
Excellent point, Nicole. Thank you very much for that, both in and hospital, out of hospital cardiac arrest. So we thought we'd share something with you. I've got something special I'd like to share with 2 very good close friends and colleagues in our region, Dr. Mickey Eisenberg and Dr. Peter Kudenchuk, regarding why performance matters. This is a short video, but it's really important to understand how sometimes the nuance or the devil's in the details of performance. So if you will, let's play this video.
Everyone is looking to improve the quality of CPR in their community, and I applaud you for making this effort. There is a science involved in learning. For example, small imperfections matter. Skills are perishable. Improvements depend on measurement. So let's explore why these things matter and why it affects the quality of CPR.
Letter-perfect CPR is critical because every detail of how we do it has an effect on outcome. Let me give you a couple of examples. We all know the importance of compression rate and compression depth. Did you know that if we deviate 1/2 inch below the 2 inches of recommended chest compression depth, survival falls by 50%? Another example, time and interruptions in CPR make a huge difference. Did you know that for every 5 seconds that we increase hands-off time before a defibrillation shock, survival will fall by 18%? Just some examples of how the details of how we perform CPR influence outcome and frankly determine the life or death of the patient we're caring for.
Excellent. We'll bring back up the conversation and away we go.
Yeah, two amazing greats from the Seattle area that really, made us start paying attention and caring about cardiac arrest.
So I agree. Thank you. And I want to thank those Drs. Kudenchuk and Mickey Eisenberg for that. So let's get into this because we're kind of pushing the time. We want to make sure we get everything in. What is high performance CPR? In a nutshell, to me, it's basically it's new age, it's new generation CPR that returns us back to performance, measurement, and improvement. That's what I think. And when we developed this program in the early 2000, it was clear to us that we were onto something. Let me share with you our definition. You look on the right, it's going to look pretty wordy, but let's do this together. We define it as a highly refined, choreographed, and measured CPR event built around mastery level individual skills with fully integrated ALS procedures incorporating current evidence-based performance metrics. And I realize that's a mouthful, but there's a lot there to chew on for a while. It makes sense in every aspect of what high performance is to us. It's both qualitative and quantitative, sharing the qualitative side. And I want to shout out to all my colleagues out there, both in and out of hospital, that I know you want to do the best you can. And most of you are already working towards some level of choreographed evolution, whether it's minimal interruptions and efficiency, calm, concise, defined team roles, interchangeable positions. These are the qualitative aspects of high performance. But look where HP takes it to a completely different level. We go to the quantitative side where every single aspect of a cardiac arrest is measured. Both, we talk about compression fractions. For those that know the AHA guidelines, I believe the bar is fairly low in my opinion. We push that way higher. If you're doing 30-2, we'll expect a 90% compression fraction. If you shift to a synchronous compression ventilation, we'd like to see 95. We expect mastery level individual skills using an acronym that I developed years ago called DVDR, stands for depth of compression, ventilation or controlled ventilation, decompression or recoil, and rate measured by a metronome. Complete integration of skills and complete scene coordination, both timed and measured against established benchmarks. That's the key to this. And there's two really big keys, Nicole. When we talk about this, when we were building this program, you and I shared this idea that we need to learn to manage the seconds of a cardiac arrest. Push away the idea of saying, are we going to run it for 20 minutes, 25 minutes, or 30? Push that aside. Let's pull back and look at 2 to 3 second evolutions and see if that makes a difference. And we manage the seconds, Nicole, by eliminating all unnecessary interruptions. And I'll speak to every practitioner out there. You and I both know we have egregious unnecessary pauses that we need to eliminate. And by doing that, you start to push compression fraction up and move to a high performance evolution. So Nicole, take it back from here and let us know what else do you think we need to do to improve.
No, I agree. Pauses are like the root of all evil in resuscitation, and you have to think about compressions as a lifeline to that patient in order to successfully resuscitate them. But in general, if you don't know what your issues are, it's really hard to improve. And back in 2013, the American Heart Association published a consensus statement saying that you should be using data that is obtained from your resuscitation devices, from your defibrillators, from CPR feedback devices to give feedback to your team. Again, you can't improve what you don't know is an issue. So almost every defibrillator on the market can give you the ability to do post-arrest review. And so basically the way this goes is whatever defibrillator you're using, whatever brand you're using, the information from that defib is sent to the cloud. And so your defib pads that you put on a patient actually can measure depth. They can measure, look at pauses, the rate that you're compressing. And then those data are sent to a cloud-based software program, which then you can analyze. But the key thing is getting feedback to your teams. If your resuscitation teams never get feedback on their performance, how are they going to improve? So this
Exactly.
is like the critical step that needs to happen. And Mike, I know in the EMS system, how quickly do you get these CPR report cards back to the
Great
medics
question.
and resuscitation
In
teams?
just a few seconds, some agencies don't do a great job. It could be within a week or two, but I'll tell you
Okay.
that there's a number of agencies, Nicole, even locally in our region, that will have the data back to the responders before they get off shift. That's how fast they
Yeah,
pull these data pieces back, annotated, ready for them.
and that would be ideal, right? If you could get feedback to your teams. But this is an example of a CPR report card and the data you can get. So you can see here, I'm just going to blow this up a little bigger. The chest compression ratio, or you'll also hear this called chest compression fraction. Basically, it's the percentage of time you're on the chest giving CPR. Remember, Mike said you want that to be a minimum of 90, but if you're doing continuous CPR, 95% would be ideal. And then chest compression rate. So the average rate, this was a very short cardiac arrest. It was a STEMI who came in and went into PEA. You can see the rates are really, really fast, anywhere from 128 to 143. That's way too fast. And I think that speaks to the adrenaline we have pumping, right?
Exactly.
And the other thing to point out here is these little red dashes indicate chest compressions. At minute 2, there was a 30-second pause for a rhythm analysis and pulse check. And so this patient did okay. They got him to the cath lab, but there's definitely some things to improve upon. So this was a facility that really focused on looking at these reports and giving feedback to their teams. And what they found is just a short 2 months later, it's a very similar arrest. It was a patient who was having a STEMI, went into PEA. It was a 6-minute arrest. You can see their chest compression or chest compression ratio is 97%. They got their rates under control by using a metronome and really minimized pauses. So it can take just a very short amount of time to see some major improvements in performance.
Outstanding case, Nicole. Outstanding.
So too, just like doing this comparison. And then this was a different hospital, different type of situation, but this is a patient who had a VFib arrest. And you can see they got shocked, and then we went until minute 7, did a 30-second pause for rhythm and check, and then shocked again. And then down at minute like 13 and a half, all the way to minute 16 and a half, here's a 2-minute, 42-second pause. Mike, if you had to guess, why do you think this team took a 2-minute, 42-second pause?
Sadly, I think I know. I'm willing to bet this was an attempt at an advanced airway.
It was, yeah. This was a 2-minute, 42-second pause in a VFib arrest patient. Now the lifeline, the thing that really makes the difference, chest compressions, were paused for 2 minutes and 42 seconds. And do you think the team were like, oh yeah, we paused for 2 minutes and 42 seconds, or do you think they were like, no way, there's no way that happened?
Yeah, they said no way.
Yeah, this is the power of getting feedback. The data don't lie. So these are definitely things that are easy to kind of cinch up. Now, another strategy a lot of EMS systems and hospitals have taken is they'll do a pre-charge on their defibrillator. So at basically like a minute 45 seconds, they'll charge their defibrillator so that it's ready to go. Take a quick look. Is this patient in a shockable rhythm or not? And you can see here, I'm in the second row. Charge was completed. They took a break at 2 minutes. Quickly saw they had a shockable rhythm, shocked, and were right back on the chest. This was about a 6-second pause.
Outstanding.
This is exactly what you want to see. And, and I think like the same if you're using mechanical CPR, which many EMS systems and hospitals use. You can just see how long it's taking you to get the device on. You can look at pauses around rhythm checks when using mechanical CPR as well. So some major big benefits on just evaluating your intra-arrest data. Now the one last kind of problem area I'm going to highlight is ventilations. So Mike, how many ventilations, if we're doing continuous CPR, how many ventilations per minute should we be giving?
Well, we use ours about every 6 to 8 seconds. So you're looking somewhere in the
Yeah.
8 maybe range, somewhere like that, 10 tops maybe.
Yeah, so it's about 10 breaths a minute if you're doing one breath every 6 seconds. But you can see this was a facility that was, you can identify these rates, 41, 45, 49, very, very fast ventilation rates. And,
Wow.
and the problem with overventilating like this is it increases the intrathoracic chest pressure, decreases venous return, has an immediate negative impact on CPR quality. And we know there's a lot of issues with ventilations. We ventilate too fast, we give too much volume. And this is something that's really easy to kind of to hone in on, have whoever's providing respirations, maybe use a stopwatch to time themselves. But this has a major negative impact. In fact, Dr. Tom Afterheide, who's out of Wisconsin, he has this quote that I love. He says hyperventilation kills in cardiac arrest and resuscitation. So if you're using capnography, this is something you can get immediate feedback on during your cardiac arrest.
Absolutely.
So with that, I'm going to hand it back over to Mike, who's going to chat about what we definitely know.
Well, this is very interesting. Gosh, I could listen to you all day, Nicole. You're really good. So the question, and you've got to get the same thing. Everyone has to ask you, how do we know this stuff? How do you know? How do I know this? Well, we track everything from our region. We are essentially data miners. We're data hogs. We go after everything. We track every aspect of a resuscitation. And in fact, we track well over 300 bits of data on every single piece of information of every cardiac arrest that we have. So we're constantly looking at the data. So I'm just want to get us through here. There we go. But look at this one, everybody. Not only do we track the data piece, but we listen to every single word that's said, because it'll help us understand where some of those egregious pauses came in. For example, that one you just shared, 2-minute pause. If you don't have an audio telling us what's going on, we would only guess. Maybe they were moving them from between the bed and the toilet or something like that. But in this case, audio helps us. So folks, we actually listen to every audio, and most all of those devices out there today have this function, and we encourage the use of audio. I've got a great case for you, and Nicole, I'm going to share this with the team. So you can have sort of a view into the window of what we look at every cardiac arrest. We look in our region somewhere around 2,000 cardiac arrests a year. Every single one is monitored and watched. And this is what we see. We're about ready to show you. There's 3 EMTs running an old LifePak 12, good old machine in AED mode. And I'm going to go ahead and play this video for you. I want you to watch and listen and see how they do. Go ahead.
Connected. Gonna analyze the rhythm. Okay, go ahead and stop to analyze. Okay, shock advised. Doing 30 compressions during shock. Can everybody clear the patient shocking? First shock delivered. Okay. We're doing continuous compressions.
Perfect. So I hope you're able to watch part of that. That was an excellent example, Nicole, of minimal pause. If you notice, they actually even charged and they actually performed compression during the charge function in AED mode. Some devices allow that. What they're doing is they're trying to shorten their pre-shock pause, that pre-shock interval, which is very important. So Nicole, when we talk about all of this stuff, the goal is to simply put the science into action or operationalize what you've got. we thought what we would do is share one more video for everybody to put it all together for you. This idea of operationalizing the science. What you're about ready to see is a team. We want to thank our team for both these two departments in the Seattle region. We asked them to come together for a training session. We told them they're going to be on camera. They brought their crew in, and everybody, this is what they did. When you watch this, try to put yourself in their position using their individual skills. What might you do when you're there? Let's play this video.
As additional EMS personnel become available, it's important to note that complete integration as a team is a hallmark of high performance, or HP CPR. HP CPR is defined as an expertly performed, choreographed out-of-hospital cardiac arrest response, consisting of highly skilled and measured individual and team performance. Here are a few things to remember. The BLS crew owns the CPR portion of the cardiac arrest scenario, and all advanced life support, or ALS, providers must be proficient in performing ALS skills without interrupting HP CPR. Do not interrupt HP CPR during the administration of ALS procedures. Rotate the compressor during the analysis of the cardiac rhythm. The ALS monitor should be pre-charged during the last 15 seconds of the cycle. The timekeeper maintains a written record of the event, crew rotations, and overall team choreography. Hallmarks of HP CPR include fully integrated, choreographed, and expertly performed resuscitation, minimal pauses, compression depth of 2 to 2.4 inches, or 50 to 60 millimeters, complete recoil, and controlled ventilation of 350 to 500 milliliters per breath.
Excellent. As we start to come back in, I hope that was a good example of trying to put all the pieces together, the operationalizing of the program, and I hope that you saw value in that. So as we move forward, I have last two slides before we'll turn it back over to my colleague. As Director of Education and Training for our region, it was clear to me we were onto something. I was given a task to put all the training into play. We have a total of 4,000 providers in our region. I was responsible for 3,000 of them. We took about a year to put all this training into play. Within 1 year, we had an increase using Utstein template, or the Utstein criteria, of a 13% increase in survival. No new people, no new drugs, no new equipment. All we did was completely change the culture of how we performed a resuscitation. It went back to measurement, performance, and improvement. And then over the following few years, using again Utstein template on this, the next 2 to 3, 4 years later, we doubled survival in our region. Nicole, this was, at this point, we really knew we were onto something, and we started sharing it with the rest of the world. Nicole?
Yeah, no, and I have to say, like on the hospital side, we definitely modeled a lot of what EMS was doing to really improve our outcomes as well. So, okay. Oh, there we go. Okay, so should we have designated cardiac arrest centers? And this is a question that's been asked in the same way that we've got level 1, level 2, level 3 trauma centers that focus on trauma care and staff are up-trained in providing trauma care. Should we have designated cardiac arrest centers? And in 2019, a study was published demonstrating that there was, when patients who were having an arrest were taken to a cardiac arrest receiving center, there was a 27% reduction in the hazard of death compared to hospitals that weren't designated as a non-cardiac or as a cardiac arrest center. And so what would a cardiac arrest center entail? Well, I mean, definitely it would entail a cath lab. It would also entail protocols for post-arrest care, and then possibly the ability to do ECMO or extracorporeal membrane oxygenation in patients who are experiencing refractory ventricular fibrillation, for example. So, you know, I don't know, we'll see. I think the pandemic has kind of curtailed a few things, but it'll be interesting to see in the next 5 to, or so years, what direction we might head with this, because I think that the data were really pretty promising. So now I'm going to jump in and talk about just some things that are starting to be used clinically that are showing some promise. one of the first things I wanted to chat about was a citizen responder app. And one of the apps that's probably been used the most is an app called PulsePoint. And so literally on your smartphone, you can download this app, and you need to register yourself with a different EMS system or city. And if your city is participating and you've got your location services on, you'll be pinged if there's a cardiac arrest within about a 2-block or so radius. And you know, and I think this can really help to mobilize people who can provide bystander CPR. And interestingly enough, when I was involved in that cardiac arrest at the airport a year and a half ago, my PulsePoint app was on and I was pinged for that. So I think it can be helpful. And the AHA is actually recommending that this technology be used in cities across the country. The next idea is drones. Can we use drones to deliver an AED to the scene? And this is actually being done in parts of Ontario, Canada right now, and being studied in the United States. It's also being studied in traumas. Can we use drones to deliver blood to patients who are bleeding in different traumatic situations? And so I don't know, I'm really excited to see where this leads us. But I will tell you that night when I was, you know, giving CPR and we were all yelling like, "Where is an AED?" I would love for a drone to show up with one. I think that would have been pretty cool. But we got an AED at minute 8 and successfully shocked the woman who was in cardiac arrest, and she was successfully resuscitated. But I think it would have been cool to get a drone there to deliver an AED. Now, regardless if you work hospital or pre-hospital, MOC codes, I feel, are essential. And I know, Mike, when I chat with you, I'm preaching to the choir on this. But not only should we focus on training individual skills, there also needs to be a focus on how your team performs. And so these are just different pictures from different MOC codes we've done. And I'll tell you, when you do MOC codes, you can really highlight issues with your system, equipment, training issues can be identified as well. And you know, MOC codes are really the purpose of them is in a non-threatening situation, have a team perform, and then do a really solid debriefing and to identify what types of issues you may have encountered during the MOC code. So you know, I think it can be really promising. All right, so we're going to kind of lead to a wrap up here, but Mike, quickly, do you mind telling everyone about what's coming with the RQI, resuscitation quality improvement?
Sure, just briefly, it really incorporates the entire team of a team evolution. Instead of individual skills, it couples that with a team scenario, showing video feedback, giving you the analytics we just talked about, depth, rate, compression, and compression fraction. So this is, I think we're going to see this in the very near future as a product that's out there, Nicole.
Yeah, I'm really excited to see what the next evolution is going to look like. Now, I'm going to go through some cutting edge innovations for cardiac arrest. Many of you might be using ultrasound, and there's actually an algorithm that can be used to incorporate ultrasound during cardiac arrest. It's called the CASA exam. So basically, again, the focus needs to be on high performance CPR. The thing you do not want happening is holding CPR just to do an ultrasound exam, and that's really important. But the idea being, can we use ultrasound to very quickly identify anything that's reversible? So first break, ultrasound, is there cardiac tamponade? That break should be less than 10 seconds, get back on the chest. Second break, is there right ventricular dilation, which could be indicative of a pulmonary embolism? The third break, is there maybe some cardiac activity that we're not seeing? So you should not hold up CPR just to do ultrasound. This needs to be done at the breaks. So this is actually a patient whose monitor was showing asystole, and what you can see is that you can tell the ventricle is fibrillating there. So the bedside monitor showed asystole, but the patient was actually in VFib. So then they were able to shock this patient. A big, huge thank you to Mike McAvoy for letting me use this video. So do we have tamponade? You can see here we've got a heart that's literally right side of the heart is collapsing on itself because there's so much blood compressing the heart. So that is, we can do pericardiocentesis during cardiac arrest to mitigate the cause of that arrest. This is an example of an ultrasound showing massive right ventricular dilation, which is often indicative of a pulmonary embolism. In this case, you know, we can either do thrombectomy or we can give TPA. So it can be super, super helpful to identify reversible causes of cardiac arrest. Now, a couple other things I wanted to mention that are kind of gaining some attention in the literature. So this whole idea of heads up CPR. Now, I will say don't try this yet. We're not quite ready for prime time, but there have been some animal studies conducted and then observational studies where they used a very deliberate protocol with mechanical CPR, and they will raise the head of the bed. And this is done in a very gentle way where they, in time increments, will slowly elevate the head of the bed. And what we've been able to identify in animal studies is that by doing this, ICP decreases with head of bed elevation, cerebral perfusion pressure increases, as does coronary perfusion pressure. So again, not ready for prime time. Really thinking there's probably going to be a randomized control trial evaluating this. But this is observational data demonstrating when heads up CPR was implemented, that survival increased. We definitely need a randomized control trial to verify that, though. And then finally, the last thing I wanted to mention is the whole idea of what's called eCPR. So eCPR is a combination of therapies which include mechanical CPR, cannulation using ECMO, and then getting the patient to the cath lab if needed. But ECMO, or extracorporeal membrane oxygenation, basically we're inserting two cannulas, one on the venous side, one on the arterial side. And on the venous side, we'll take blood through a pump and an oxygenator and then return it back on the arterial side. And this basically allows for cardiopulmonary bypass. And you can see these are different different cities across the world. London, this is the London response ambulance, but you can see the ECMO devices have gotten really small. And in the United States, I would say the cities to kind of watch, which are to keep an eye on, which are starting to implement this. Minneapolis has got the biggest study that is being conducted. Dr. Dimitri Yiannopoulos and Jason Bartos are leading that. And over to the right here, this is a new mobile resuscitation type of ambulance you can see, which can be dispatched to the site. So really exciting, but we definitely need ongoing studies to identify what size cannulas we use, when should we implement ECMO, etc. All right, so with that, Mike is gonna wrap it up and bring it home and talk about where we should start.
Wonderful. Thank you very much, Nicole. Excellent work. So we're calling this our 5 top places to start. That, of course, is suggestive that you haven't started yet. So let's do this. The top 5. The reason I put this slide up there is because, quite frankly, looking at all the things it takes to increase survival from cardiac arrest can be a little daunting, right? So I want you to just think about 1 or 2 of these particular pieces and then go after them and perfect them and make sure you're successful with them, and then add another 2 or 3 down the road. But don't attack this all at once. That's a shotgun approach, and it doesn't work very well. So when Nicole and I discussed this, we thought, let's first start this. Number 1, you need to identify and enlist a team of champions within your organization. Everybody from the decision makers, the top decision makers, medical control, all the way to those practitioners that are actually performing the skill, and folks in between. Enlist and identify a team of champions to help you on your cause to increase survival in your community or your program, both in and out of hospital. The next thing is to develop a plan and train to it. By doing this, it'll help you understand gaps and strengths within your current model and identify really good programs moving forward. It also helps you identify to both validate proper performance and remediate those and performances which don't meet task. And lastly, learn to master the skill of each individual performance. Each person, I believe, must be a master in their individual skill before they can be included as a team. And you do that through feedback, instrumentation, through mannequins, and bring the team together. I've said this all the time in my training. Every person who brings their hands near the chest of this patient, cardiac arrest, brings value. Whether it's a ER tech, a nurse, an RT, a paramedic, an EMT, a nurse, a physician. It makes no difference. If you bring your hands near the chest of that patient, you bring value to this team, and your goal is to make it one. The next one, measure. You have to measure, learn to validate and remediate. You have to measure your training performance through instrumentated mannequins, right? To put them together, understand where you're at. You need to measure your actual post-event analytics, the real calls. As Nicole said, every device has the ability to track those data. Look at those, review, and get them back to the responders, which is the third one. Develop a feedback loop. If these responders never know how they've done, they can never improve. Our quote is always, you don't improve what you don't measure. Number 4, understand and embrace whatever data you have. In the EMS arena, often CARES reporting, cardiac arrest resuscitation reporting around the United States, or maybe it's get with the guidelines database in hospitals, or maybe you don't have any of those and you've got your own internal database, or maybe even a state database. Here's where I'm going. Report your data. Acquire and report your data. From there, you can share your data with others to learn from them and just possibly have them learn from you. And number 5, the first thing you see here is this young woman. Let me explain briefly. She was actually a cardiac arrest, she's a nurse, cardiac arrest lead in her hospital, pregnant at the time with that young lad in her arms. She went into cardiac arrest at home, still pregnant, 3rd trimester. Husband started CPR, neighbors came over, EMS, EMS to hospital, hospital to ICU. And this woman survived this event to stand on the stage 3 years ago in Seattle and share the importance of a survivor from cardiac arrest holding the very son that she was pregnant with at the time. Folks, embrace and share your success. It is difficult to run a positive and effective and efficient cardiac arrest, but it can be done. In our organization, we do either survivor coins or save a mugs, but once a year we have survivor luncheons. We bring the people, the very people that we help survive, to include hospital and pre-hospital, and we do a luncheon. And post the updates within your organization. Let your teams know how you're doing. And with that, I know we're extending by a few minutes. This has been so fun to do this with you, Nicole, and I wish I could see all of the responders around the world that are here today. But James, I'm ready to take it to you and take us home.
You got it. Absolutely. Thank you so much for that, Mike and Nicole. We really appreciate it. And I just wanted to give everyone a chance to sort of do a time check here. Just so you know, we have my clock is saying 3, but it's probably more like 2 minutes to the top of the hour. I'm going to give you all the particulars about your CE. We're going to wrap this up, and then we're actually going to extend for about 4 or 5 minutes for just a couple of questions. Okay, there you got a lot of questions, but they were sort of grouped in sort of topics, so we're going to go over the topics. Okay, so for those of you who need to leave at the top of the hour, please feel free to do so. I'll walk you through the particulars now. For those of you that can stay on for a few minutes, Mike and Nicole have graciously agreed behind the scenes here to stay on for a few more minutes. So with that being said, this is good, of course, for 1 contact hour of CE. And as you can see on the screen here, for nurses and RTs, you're going to go to www, and you do have to put in the www, by the way, www.sacstesting.com/SL to get your continuing education for nurses and RTs. For EMS folks, y'all are going to go to www.sacstesting.com/EMS. Okay, pretty simple. For everyone then, once you get there, you'll need to register on the site, of course, complete an evaluation form. Once you're done with that and submit, you'll be able to print your certificate of completion, okay? We also, of course, want to take just a moment to say thank you to Stryker for your support of this educational activity. Also, for those of you who might have missed some things, there were lots of questions about that in the chat today. If you missed some things, there's an archive version of this that will be available for you on savinglivesnow.org, okay? When that is available, we'll send out an email to all the registrants. So whoever was the primary email person, you'll get an email that says it's ready. Go to savinglivesnow.org, and the on-demand version is accredited for nurses and RTs only for your CE, okay? Unfortunately, EMS folks, you will not get CEs from the archive version. Okay, that being said, it's the top of the hour. If you need to leave, please feel free to do so. And we thank you so very much for coming. This was awesome. The videos and the stories and I was like holding my breath during that, was it 2 minute and 42 seconds, right? And I was like, oh, they're intubating. Of course they're intubating. I know that they're intubating. Like I was freaking out by that. Which Mike and Nicole, I open this up to either of you who want to take this on. There were quite a few questions about, okay, 2 minutes and 42 seconds is obviously way too long. Is there a reasonable amount of time to stop? Keyword stop CPR for intubation.
Sure. Can I take this first since we worked very hard on this in the early 2000s? The answer is on surface, the answer is no. Let's just take it on the surface. The answer is no. Intubation should be a skill that can be learned, trained, and taught and reviewed, measured during compressions. So on the surface. So let's say though, you take a look and the Malampati is poor, you realize you're not going to get that, then the answer is yes. If you need to do that, whether you're using an endotracheal intubation or supraglottic airway, some advanced airway, if you have to stop, make it short. Our interval for pause should be nothing more than 10 seconds. That is the maximum pause for anything. But the answer is you shouldn't have to stop to intubate or place a supraglottic. Nicole?
I'm not going to add anything to that. That's dead on.
Yep, there you go. And I challenge every of you out there, all of you out there, we went through the same thing ourselves because we, like you, were taught the old way. Stop to do any advanced airway. We had to change our entire culture, everybody. I can tell you firsthand, it can be done. It can be done.
That's really great to hear that, because it is a culture change, right? And that changing culture is so difficult. You know, you can teach things over and over again, but if the culture of something, particularly in a high stress, high stakes situation. So a couple of little questions that I was like, oh, these guys need to take one of Nicole's training. But they just, one of them, what is the rate of ventilation in a non-intubated patient, right? If we're not going to take the time to intubate this patient, what's that rate of ventilation?
Yeah, I mean, a lot of times we'll do 30 to 2. A lot of facilities, a lot of EMS agencies, regardless of whether they have an advanced airway or not, might opt to do continuous compressions, and which would be 1 breath every 6 seconds. So it's asynchronous. And Mike, can you tell them how you do, you guys ventilate on the upstroke?
Absolutely. Oh, first of all, great question. Whoever asked that, thank you for that.
Yeah.
And we are talking in cardiac arrest. The timing, if you're using 30 to 2, it's fine. As you know, it takes about 16 seconds to get in 30 compressions, in which case you can stop for 1 to 1.5 seconds per breath. In continuous, Nicole, we actually start the ventilation we do the ventilation on the upstroke of the 10th compression. Now, there's some agencies do it on the upstroke of the 12th or the 15th. That way they don't overventilate, hyperventilate. But we put a little air in on the downstroke. We don't try to ventilate there, but then we finish it on the upstroke. So that's essentially asynchronous. And we developed BLS continuous compressions with not an advanced airway almost 16 years ago. In fact, my colleagues at Seattle Fire are doing BLS continuous compressions without an advanced airway currently.
Now, why? I'm just going to ask this, or Nicole, maybe you were going to answer this. Why on the upstroke? I mean, I feel like anatomically, physiologically, it makes sense, but humor me. Why? Why on the upstroke?
Want me to take that?
Yeah, go ahead. Yeah.
Sure. Because as you know, James, you can't put air in during a compression. All you're going to hear is a.
Right.
Am I doing that okay on camera here? So in fact, we even know if you're trying to ventilate during a compression, it just doesn't go well. We're only looking for 350 to 500 on a normal size adult anyway. So we're only looking for the initiation of chest rise. So on that upstroke with a fairly focused, we actually use a 3-finger technique. So we're not trying to ram it home. We're actually, yeah, you like that, the little 3-finger pinky thing. We actually do just fine with it. Yep. That's why, James, thanks for the question.
That's perfect. All right, it's 4 minutes after. This will be the last question, and then we really do have to wrap up. Thank you so much. So many hundreds of you have stayed on. We really, really appreciate this. let me see if I can pick. I picked several of them. That there's so many good questions. I'm sorry we can't get to everything. AHA has pushed RQI as the preferred training method. Is there any independent evidence that RQI has made an impact on meaningful survival after cardiac arrest?
I think that would be a hard tie. I don't know. That would be a really hard direct tie to make. You know, it'd be like saying, do the mock codes we do have an outcome on cardiac arrest? Like that causal relationship would be hard to make. So I don't know. Like I'd have to do another lit search to see like if there's anything like an observational study that has demonstrated bringing in RQI then led to. But again, that's not a causal relationship. I don't know, Mike, do you know of anything that's been published?
Yeah, I can imagine that there's certainly a number of team members on that side that would be able to cite some of those ideas. But let's just push back for a second. James, let's just ask this question, regardless of product. Do we believe that increased performance, maintenance, efficiency, measurement, and remediation, do we believe that will in turn increase performance in the street or field or in hospital, which could therefore increase survival? I think that part seems pretty clear. Now, whether a particular model can tag itself to that, I think we need to reach out to that group to ask that question.
I agree.
Excellent. Very good. Thank you so much for staying on for a couple of minutes afterwards, and the 700 of you that also stayed on afterwards to answer some of these questions. And with that, I thank you so much. I thank everyone for watching. And Tracy can wrap us up.
Thank you, James, and thanks to both our speakers. We'd also like to thank everyone for attending today's session. A reminder, the survey, immediately upon the conclusion of this webinar, you will be presented with an online survey. So please keep your web browser open, and we appreciate your feedback. For the CE certificates of completion, 1 hour following the conclusion of this webinar, you will receive an email with instructions and a link to obtain your CE credits. The nurses and RTs is www.saxtexting.com/SL and EMS www.saxtesting.com EMS. Thanks so much and have a great rest of your day.